I say how to do? Open up YouTube Studio dashboard. Settings. Uh, Settings of the stream. YouTube Studio dashboard. Oh, fuck. Where would it be?
Good morning. But we don't
Morning.
have, the recording is not on yet, correct?
Correct.
Okay.
Did you get my email regarding the Nashpee? I cannot get it.
What do you mean you can't get it?
As you sent it to me, I could not use it to share. I needed like a PDF or PowerPoint, so I could start it from a slide point. It's coming up like in 1, 2, 3, and then it won't be able to.
All right. Let me see. Is there a way to pause the YouTube until we start? It says it's live. Let's see.
Hold on one second. Let me see. I don't think we're up on YouTube, are we?
Pretty
Yeah,
sure
we
I
are.
see. Hang on a second. I need to make sure I have the right presentation here. Okay, this looks like it. Just make sure. Oops. Okay. Marilyn will be joining this morning. Not Maureen. So when you see Marilyn Barnett, that's who you should let in. From Nashpee.
Okay.
Okay. Okay. Let's make sure you got that. Need to pull up the agenda. Okay. Okay.
You emailed it to me, Vicki?
Did you get it?
No, not yet.
I just. There's Marilyn. Morning.
Good morning.
Let me know if you don't get it. I sent it at 8:56. Should be there. So I can always run it if you don't get it.
Good morning, Vicki.
How are you?
Good, and how are you guys doing? Thanks for that.
Good. Yes, thanks for joining us. We just have a couple things to get to before you go, Marilyn, that some procedural and then one short presentation, and then we'll be all set.
Great.
For you. Come your way yet, Maida?
Just received it.
Okay.
Got it.
Good morning, all.
Morning.
Hey, James.
Good morning. Good morning.
Morning.
Good morning.
We're filling up
Morning.
the
Good morning.
cabinet. Good morning, everybody. This is our first experiment with using, we're learning to do it how the legislature does it. We're trying to also stream on live on YouTube to see.
Okay.
Apparently, we are actually live on YouTube. So if you don't want anybody to know what you're saying right now, you may not want to say anything. So the meeting- We'll have to figure
Good
that one
morning,
out for the
everyone.
next meeting. Morning, Reverend Anderson.
Morning.
How are you?
Good, how are
Good
you?
morning.
Okay, let me see.
It's a minor detail that I need to address.
We're learning as we go. We'll get there. Okay. I can see it looks like we already may have a quorum. Let's see. Okay. Just trying to do the count here simultaneously. This is not easy. 1, 2. 6, 7, 8, 9, 10, 11,
I
12.
have 11.
Okay, I had 12, but I think I might have counted Sean and Ted together. So, well, here's Paul, so I think we're fine. 12 is a quorum, 12 or 13?
11.
Oh, okay, so we're at a quorum. Okay, let me give it 1 second. You tell me if we have anybody else still coming in, and then I'll launch in. Oh, there's Alan, okay.
Okay.
Everybody in?
I think everybody's in at the moment, yes. So I'll start recording.
Okay, well, then we'll start. All right, good morning, everybody. Welcome to the Healthcare Cabinet meeting on March 8th. It's 9:02, call the meeting to order and welcome lots of folks. We are trying to live stream this at YouTube at the same time, so we're learning how to do that as we go. But apparently the live stream is active on YouTube because people are watching it. So well done, Maida, for our first shot at doing a YouTube simulcast. So I'm going to open the meeting to public comment. That's our first substantive item on the agenda. Is there anybody who has a public comment who is on here today? If so, please raise your hand using the tool, or if you want to speak up, I can call on you. I'm not, don't know who this person is, apologize. Any public comment? Okay, it doesn't seem like we have any public comment. If you're having technical difficulties, just let us know later and we'll try to get you on for public comment. The next item on the agenda is approval of the January 11th, 2022 minutes. Could I have a motion to approve the minutes, please?
Madam Chair, so moved. James Michelle.
Second.
Seconded by Pat. Thank you. Are there any questions or comments on the meeting minutes? None? Okay, all cabinet members in favor of approving the cabinet meeting minutes from January 11th, please say aye.
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 Are there any no votes? No. Any abstentions? Okay, no. The motion carries. And if folks could please do me a favor, if you're not speaking, to please go on mute because we do have a large group today. That would be welcome. Not that I don't want to hear all of you, it just will save us on feedback. So the motion carried. Let's move on to the next item, which is item 4, and this will be an update from James Michelle, who's the CEO of Access Health. He moved on my screen, so I don't know where he is anymore. James, good morning.
Good morning.
And I believe we might have a presentation from you, so I
Yes,
think
we do.
somebody's working on getting that up there, and there we go.
Great. Thank you very much, Madam Chair. Good morning, all, and thank you for the opportunity to give you an update on several items that Access Health is currently working on. First, I'm going to start. Next slide, please. A quick update, summary of the end of the 2022 open enrollment period, which ended on January 15th, 2022. This year, we ended up about 7.9 to 7.4% higher than last year's open enrollment total. Again, we are at 112,634 as of on January 15th. Of that amount, 84% of enrollees now eligible for financial help. This is 14% higher than 2021. And this is mostly due to the ARPA removal of the 400% cliff, meaning that anyone who earned more than 400% of the federal poverty level were not eligible for any subsidy. That threshold went out the window. So we have a lot of folks who now who used to pay between $1,000 to $2,000, in some cases $3,000 a month for healthcare. They are paying dollars on a monthly basis because they are not eligible for healthcare for subsidy. We do have a very detailed report that's on our website. As stated there, that gives you all the details about how we ended the year. Thank you. Next slide, please. Update on the Broker Academy. The online application has been very active. So far, as of yesterday, we have 81 applicants. And again, the whole program will be going on until mid-May. Our goal is to get 100 applicants, and we are going through the process now with those who have already applied for them to submit the additional documentation that we need from them, such as references and recommendations, as well as resumes and so forth. So once we have that in place, we will get going. The training is scheduled to start on June 1st to end by the end of June, and exams taken in early July between July and August, in anticipation of having all those brokers ready to go to team them up with experienced brokers so we can get the development that they need as they prepare for the 2023 open enrollment, which starts on November 1st. We have been going around the state making a great deal of presentations to elected officials as well as community leaders to engage with them to get more applicants in the front door. If we get more than 100, we will not turn anybody away. We will just create a waiting list. That way, if we have anyone that drops off, then we have a list to go to do backfill. Thank you. And one thing we have done, we have developed a number of teams within Access Health to implement different parts of the project plan for the Broker Academy. So the entire company is now engaged in making sure this is a success. Thank you. Next slide, please. Culver, Connecticut, marketing update very quickly. You may have heard we did extend the special enrollment to June 30th of 2022. And along with that, we have started doing a lot of outreach, we've connected with our partners, sharing information with our partners, sharing information with our elected officials and our board members to push out about the special enrollment that extended specifically for Culver, Connecticut to June 30th. We have employees at Access Health where that's all they do. We have a special number. So if anyone call Access Health looking for Culver, Connecticut, they'll be patched to one of our employees who specializes in making this as painless, as quickly, as easy as possible for anyone who qualifies. And it's Monday through Friday, 8 to 4. And we shared the document on the right facing you of the family, the Culver Connecticut program. It gives a lot of detailed information about what it is, who will qualify, what are the thresholds. And that's been shared elected officials, with our community partners, they're pushing that out as well. And we've been on TV. We've been on other targeted communities where we know some of those who may qualify currently live. And this is a sample of the areas that we have focused on getting the word out. And currently, we have 855 Connecticut residents enrolled in Cover Connecticut. Next slide, please. All right. This is currently what we are doing right now on the left side. And on July 1st, we will expand, assuming that the Cover Connecticut phase 2 kicks in on July 1st. We have a whole marketing and outreach strategy about getting the word out. But currently, we are continuing through print media, social media, both paid and organic. We have a blog, we have a Q&A area on our website where we share a lot of information about Cover Connecticut. And we've been in the communities, we've done press release, we've attended community events to get the word out. Thank you. Next slide, please. American Rescue Plan, very quickly, the subsidy extension. We have been working very closely with our elected officials in DC, give them information for them to talk about the impact of the premium tax credit, the enhanced premium tax credit going away, what the impact would be to Connecticut residents in the entire state. So again, some of the benefits, more people are enrolled because it's more affordable for Connecticut residents. And also we've noticed this particular year, a lot of folks have upgraded their coverage. You know, they went from a bronze plan to a silver plan, or from silver to a gold, meaning that they could afford more coverage because it's affordable for them because of the advanced premium tax credit that they are now eligible for, which they weren't prior to offer. And all we know that we tracking this, we know this should also benefit, help us to reduce health disparities as more people become eligible for health insurance. Next slide, please. Yeah, I'm talking a bit about the public health emergency in Medicaid redetermination planning. Currently, the public health emergency is extended through April 16th, and we have been informed by CMS that's going to be extended another 90 days, which will take us to mid-July. We have been working with DSS ever since the PHE started to update our system, and so that it's as smooth as possible for Connecticut residents to continue to stay on Medicaid. Our biggest concern at this point is when the PHE, when it ends, the impact this would have on our folks in Connecticut. Now, right now, just some quick data point. Right now, there are 893,000 Connecticut residents who are currently on Medicaid. Of that amount, about 310,000, almost 311,000 are on Medicaid extension. So most of them will probably be redetermined to stay on Medicaid, but those who do not, we have to find a way to make sure it's as easy as possible for them to continue to have health coverage. And so we will work very closely with DSS to put together a communication strategy as well as update our system. Now, one of the concerns that we have is all those folks losing coverage in one day. CMS has indicated that they would allow states to spread it out over a 12-month period. The only question there is those folks who stay on Medicaid for 12 months, and if they're not, if they weren't eligible for Medicaid, will the federal government continue to cover their Medicaid costs? That's a question I had posed to the CMS when we met with them last month, and they did not have an answer for that. Again, those who do not qualify for Medicaid, when we do redetermination, the question would be, what would they be eligible for within Access Health? And this in communication in advance of any changes is key to making sure everyone continues to have continuing coverage, especially if someone who is who has chronic illness and is who's in need of continuous medical support as well as medication. They cannot afford to have any disruptions at all into the medical care. So that is one of our biggest focus as we move forward in terms of transitioning and communicating to those who may not qualify for Medicaid once PHE ends. Next slide, please.
That's it. That's all I have.
Okay, so thank you very much. One of our biggest concerns as we communicate with our biggest concern right now by far is if ARPA, the American Rescue Plan, is not updated to continue beyond December 22nd. As you know, our board met, our subcommittee of our board met last week and have voted to forward to the board the Access Health Board plans, their approval recommending parameters for the standard plans for 2023. The rates for 2023 are determined by July, September. They'll be determined. And without knowing what's going to happen to ARPA, it makes it very difficult and challenging for the insurance companies and insurance department to determine exactly how to calculate what the rates are going to be. Because we anticipate that folks don't have the support, the enhanced APTCs from the American Rescue Plan, they may not get coverage. This would have an impact on the pool of insureds, which would definitely have an impact on rates. So it's going to be very complicated, and for the insurance carriers and insurance department to make that determination in late summer, early fall. Madam Chair, this completes my presentation.
Thank
Any
you,
questions?
James.
Thank you.
Lots of complicated things happening at once.
Yes.
The PHE potentially coming to an end and all that time. And the very big challenge that the state has on redetermining people potentially who might be eligible for, I see Bill's face here, Bill Halsey from DSS, who potentially may still be eligible for Medicaid or may be coming off, may be eligible for Covered Connecticut, at the same time waiting for the feds to handle the ARPA subsidy situation, which is a dramatic impact on not just Connecticut, but across the country if those subsidies are not extended for coverage next year. I'm going to open it up for questions. Just want to remind people, we have a lot of people on this call today. The cabinet members can ask questions, and there's going to be a lot of people listening, but if you're a member of the cabinet, obviously you can ask questions, and I will get to you in the order that I see you raising hands. So with that, oh, wait a minute, 1 second. Before I do that, I just want to remind people, please, if you can, please avoid the chat function. I would appreciate it. We are at a public meeting. It's very hard for me to track the chat function and chair the meeting. So if you have a comment, I would prefer if you just raise your hand and we will call on you. So with that, Ted, go ahead.
Oh yeah, thanks so much, Vicki. Good morning, everybody. Ted Doolittle, Officer of the Healthcare Advocate. I just wanted to point out real quickly, Vicki and James, that on Thursday, CMS added 2 months, so it's now a 14-month period. I did send Maida a link to a news story in case you want to put it in the chat for folks. Thanks so much.
Okay, thanks, Ted. Yes, I saw that come out on my Twitter feed, actually. Thanks for that. We'll share that around with people. Ellen?
Yeah, a couple of, well, one is a favor. If when you get an answer from CMS about whether we'll get paid for that time, because we should do it right and we don't want to burden either families or DSS. We want to get it right. So take as much time as we can. But when you get an answer from CMS or anybody else on this call does, can you let us know? Because that could be, it depends on how many, end up being eligible, but that could be a very large ticket item and, taxes are, you have an unlimited budget.
How are you?
I am well.
Can you do me a favor?
Sure.
Can you reach out to
Some people
Ken
or- Okay. Just a reminder, if you're
question-
not speaking, to please go on mute. Sorry, Ellen. I didn't mean to-
No problem.
ahead.
The ARPA ending worries me a great deal. And I just think about whether it's possible, first of all, letting people know ahead of time that this may be happening when they sign up, so it's not a surprise to anyone. And is there a way to structure rates so that they can make a choice to pay more at all through the entire year in case it happens, and then they get a lucky, 3 months free at the end, just so to help families, continue through the entire year, get continuous care and plan for it ahead. Just give them that option.
So that's a question that I think I probably should send over to Paul, who's on. Sorry, Paul.
Yeah, James, you were going to say something. Go ahead, and then I'll
Go ahead,
follow
James.
you
I
up.
didn't mean to cut you off.
No, I was going to say the insurance companies, 12 months premium is how they calculate their annual premium. Anything less than that, it complicates. It may add cost to it. So that's all I was going to say, Paul.
Yeah, so Ellen and everyone else, the premium stays the same. Okay, the premium that they file with the insurance department is the same regardless of whether there's additional ARPA subsidies or not. This is behind the scenes calculations from Access Health CT administrating the subsidies. So the premiums are set, and what we approve will be the same rate regardless of whether ARPA continues to exist or not. It's the behind the scenes, how much they actually have to pay as a result of ARPA either continuing or ARPA not continuing. That doesn't have any impact on the premium that the department reviews and approves.
Right.
Does that make sense?
No, it does. We do this like with utility bills. You don't have to pay a huge amount in the winter. You can spread it out over a year. Is there some way we can do that for families then maybe that's a question for James, whether we can do that for people. I don't know if anyone would want that. Maybe they want lower costs up front. I'm just really worried people will fall off a cliff, and maybe for an extra few bucks a month, they could get it for the whole year.
Yeah, well, Ellen, the billing part is done by the insurance companies. As Paul indicated, we get the information based on your income. We determine how much APTC you are eligible for. We apply that to your premium. Then the insurance company sends out the bill. So this is something insurance companies would have to work out with their customers directly.
But it could be, right, but it could be that Access Health could facilitate the offer. So we need to talk to the insurance companies. I don't know. I'm not seeing a name, and plus I wouldn't put somebody on can we ask them if they can do that? If there's a way to do that? And it's only if, God forbid, ARPA goes away.
Yeah, we will follow up with them, see if they're open to working out payment plans with their customers.
Great.
Yeah, we're trying to be optimistic. Here where you're coming from, but we are trying to be optimistic about our planning. That said, we're waiting for the signal from Congress that this is going to be included in a budget, even a reconciliation item. Seems to be not one of the most controversial pieces to continue this, but they have to get it done. So I hear where you're coming from on it.
And I think we need to prepare, and we need to prepare families for the eventuality. I think hope is nice. Hope is great, but plan.
It's not, but you're right. We had a saying we had a saying in the Army, we need hope, but it's not a plan. All right. But however, we will have a whole communication strategy. If by September, we don't have any indication at all where ARPA is going to end up, then we'll start communicating with folks as early as possible. We think by July, August, we have a pretty good indication what the impact is going to be. We've guesstimated. In fact, we know what the impact will be if ARPA went away today, what the impact would be to our customers right now, and you could extend it into next year with new premiums. So we know it will be dramatic for a lot of folks in Connecticut.
Great.
Benjamin. So the communication will be a big part of our strategy to make sure people, Connecticut residents continue to have continued coverage so that there's no interruption to their healthcare needs.
Thank
And
you.
again, not just a Connecticut issue, a national issue, which is why it's so critical.
Right.
That needs to be keeping stressed how many millions of people were able to get coverage this year because of the subsidy.
Madam Chair, we do have a one-page document that we forwarded. I think we forwarded to the board last week or before last, as well as our elected officials. With your permission, can I forward it to this whole group as well? We send it to MEDA, then we can send it to the whole group so that they have a one page that describes exactly what the impact would be to Connecticut residents if ARPA were to go away.
That sounds great.
Okay.
And regarding Cover Connecticut, I just want to say thank you for extending the open enrollment through June. It's really critical that now that we have this program, we want people to have a chance to maximize the opportunities to actually enroll in the program. And so I guess one of my questions is, do we have, or James, maybe we can talk later, if there's a trigger on the website at the top to tell people, I know we have I think there's a special enrollment banner. I don't know if there's something on that banner that says Cover Connecticut, or there's a way to let somebody know that they may still have the opportunity for Connecticut there, but that might be helpful.
Will do.
May be eligible.
We'll do,
Thank you.
Vicky. We'll follow up, but we know the best way to get to the population we are focused on is through the community partners, because that's where people go for help. So that we have a lot of energy focused on working with our community partners to guide folks to Cover Connecticut.
Yeah, and very much appreciate that. Thank you.
Yes.
That is a lift, and we're all going to be working hard together as the PHE starts unwinding. We have a lot of work to do together. And everybody on this group here could be helpful with respect to that. So are there any more questions for James? Somebody tell me if I'm missing any hands. I don't see any. Okay. Thank you, James, so much.
Thank you
for
much.
the
Thank
presentation.
you.
Okay, now, according to my agenda, if I'm correct, yes, we are moving on to the next item. And I want to introduce Marilyn Bartlett. She's here from NASHP, National Academy of State Health Policy. NASHP has developed a tool over the last year or so. Marilyn can correct me. And the states work, in case you all don't know, NASHP is a policy group that lots and lots of state people like me and others on this call work with on various issues. And just one of the things NASHP has been working on is this tool that we're sharing today. And we're trying to make data more available as we go along. OHS is on tools that come out, and we want to share this with the cabinet today. Hope people find it interesting, ask for comments, questions, and I'm sure Marilyn will be more than happy to answer any questions about it. But I think it's an important tool to share with people, one of many, and want to say that we're sharing this for the purposes of education and so people understand financing. And we welcome any comments by anybody, including hospitals who are on this call today. So I will turn it over to Marilyn, and I think Maida is going to run your slides, Marilyn.
Thank you. Thank you, Vicki. Thank you for the introduction. It's a pleasure to be here, and we appreciate being able to work with you and your team. As Vicki introduced, I'll be sharing with you the hospital cost tool that we've developed at NASHP. Next slide, please. So what is the hospital cost tool? It's a downloadable tool. The link is on our site, and it is used to help healthcare purchasers. We work a lot with state employee health plans as well as employer health plans, and also with state officials to better understand and address hospital costs. And we have been using it to help with hospital rate negotiations. We've been using it with states looking at pre and post merger financial performance coming out of a COPA. Vertical integration or consolidation. So we've had numerous uses for it. The tool is based on the Medicare cost report, which every hospital that has Medicare patients must annually submit and verify and sign off on the accuracy of this report. It's hospital level data and really the only national public source of hospital costs, their hospital costs and their data. The tool was developed by NASHB, but we worked with Rice University through the process to validate the information, validate the data. And then we had support from Arnold Ventures to put all this together. Next slide, please. So this slide can be a little bit overwhelming, but I just want to explain the basic process. The first step is we access the hospital's Medicare cost report. Those are filed annually by the hospital's fiscal year. And it's at the hospital level, not the system level. We then input specific data from that report. In number 2, you can see in the green cells, dollars are entered. And to the right is the reference of the Medicare cost report site where we get that number. And then the result, number 3, is that the tool includes calculations that can come up with data and information that is helpful to a state. Or you can see profit loss, you can see different profits per patients, et cetera. And we provide the link here. One thing that's been great is that Rice University and their researchers have helped us link this tool to the HCRAS database, which contains the Medicare cost report data fields for 6,500 hospitals for 10 years. So we've been able to link that so you don't have to fill out that Excel tool anymore. And we'll be rolling that out in April, just next month, an interactive dashboard that anybody can use to look at this data in a very user-friendly fashion. Next slide. So one measure of the tool is the break-even analysis. And I used this quite a bit when I was negotiating in Montana for reference-based pricing contracting for the state of Montana Employee Health Plan. And what break-even is it's the point when the hospital's revenue equals their expenses. So there's zero profit. It's what do I need to make to at least break even? And the expenses that we include are the hospital operation, it's ancillary services, administration, and we bring in all the non-operating income and expense. So it's the total picture of the hospital. So the commercial break even that we calculate is what would a commercial payer have to pay a hospital as a multiple of Medicare for that hospital to break even. We then compare it to the RAND 3.0 study. RAND 3.0 looks at inpatient, outpatient prices that are paid by the pool that have submitted their claims. And we compare that because we're comparing apples to apples. Now, to the right of this slide, you'll see how break-even works in our tool. The green bar shows for Hospital A that they could break even at 150% of the Medicare rate if that was charged to commercial. The little red dot at the top shows for that particular hospital what the RAND 3.0 study showed was the price for inpatient, outpatient that the commercial payers paid. And the RAND price is a blend. It's an aggregate of 2016 to 2018 prices. Next slide, please. So there's factors that can impact the break-even point. One is we base the break-even point on what that particular hospital's Medicare reimbursement rates are. So the reimbursement rate takes into account wage adjustments, geography, different types of factors. So one hospital's Medicare reimbursement rate will be different than another's. Well, we base our reimbursement, our calculation as a multiple of Medicare on that specific hospital. So if that hospital is making a profit on Medicare, then the break even would be lower because you're already paying more than 100% of the costs. Hospital other income comes into play. If a hospital is making a lot on investments, the federal relief payments, then the break even point would be lower. We include reimbursements from other payers. So if that particular hospital is having a loss on Medicaid, Medicare, any of the public payers, this commercial break-even point will cover those losses to bring the hospital to break even. And of course, there's always reporting errors, unfortunately, but the Medicare cost reports are completed by the hospital or their contractor, and they are verified or signed by the hospital administration that it is accurate. But that doesn't mean that there might be some problems that maybe a field is left out and they have to verify the accuracy on that. Next slide. So we took a look at the break-even points for Connecticut and connecting neighboring states, and this is from 2019 data. And we compared it to national. So this is what the hospital would charge a commercial payer to allow that hospital to break even. We start with Massachusetts on the far left side at 100% of Medicare. Charging Medicare rates would allow them to break even. And then we moved clear to the right to New Jersey at 145% of Medicare. Now you'll see Connecticut is right in there, right next to New Jersey. They came in at 131%. So for inpatient, outpatient blended in 2019, commercial could have paid 131% of Medicare to allow that hospital to break even. Next slide. So we took a look at 2020. Now we expected to see perhaps expenses go up with COVID and the hospital expenses, but then also we do take into account the reported amounts received from FEMA, received from the public relief funds, different types of the provider relief funds, different types. Well, you'll see the change there. And where we were at 131% before with Connecticut, it's a little bit higher than that, but still it's around 135%. So it really didn't go up extremely a lot. What was interesting to me is the national average went down in 2019, and I shouldn't say national average. You know, I'm an accountant. We do these averages, but these are medians, and I'm learning to work with economists that use medians. So this is the median break-even point. The national median was 127% in 2019. It dropped to 114% nationwide. And most of that is the result of the federal funds, the market, and some other factors that did help the hospitals out. So next slide. Here's our comparison. We're comparing 2019 in the light green bar to 2020 in the dark green bar. And you can see the first three, Massachusetts, New York, national, all showed a lower break-even point in 2020. But then the last three states, including Connecticut, did show an increase. Next slide. So then we thought, let's take a look at the health systems within Connecticut. So for this particular one, we looked for, we named a system was a system that has two or more hospitals. So any, all of those are listed here. We have Prospect Medical Holdings on up to Western Connecticut Health Network. Systems, again, that have two or more hospitals in the state. So let's compare this to RAND. First of all, let's look at Prospect. Their break-even point is slightly over 100%. The RAND price is really running around 180%. So that spread there between those two, between the green bar and the red dot, is what I used in Montana to negotiate. I wanted to pay a multiple of Medicare, and I wanted to negotiate a rate that would be fair to the hospital. They wouldn't close their doors, yet might drive efficiency and would also drive lower costs for the taxpayers and the members of the health plan. As we go across, you can see the biggest spread is Hartford Healthcare Corporation. The break-even point is running around 125% of Medicare, but you can see that the blended inpatient outpatient is over 200. Now, there's interesting things with the break-even point that we look at that we can dig further into the tool to say, is the break-even point high because costs are high? Is it high because they're losing money on government programs? Why is that break-even level high? Or in some cases, efficiency can be an issue. So we typically can drill down further in the tool. But I wanted to show you this as 2019, making this comparison. So let's go to 2020. Next slide. This is the same thing. We're looking at the systems and we're looking at the break-even point and we're looking at the multiple of, or the RAND price. We see that Hartford Healthcare had a bigger spread. We also see, as we move across, that Western Connecticut is still on the far end with a higher break-even point and the highest price, basically. So all of this ties together, as you can see, because those break-even points changed in those earlier slides that we saw, but the RAND stayed consistent. Next slide. Again, here is the comparison from the major health systems. Again, the drop we see was a lot due to the federal funds that became available. And just showing you the trend between the years. Next slide. So then we looked at two of the systems. You'll see that we focused on Yale, New Haven, and then we also looked at Hartford. And what we wanted to look at was the counties. Was there any difference in the regions? We looked at the counties that had many Yale, New Haven system beds is what we looked at. So this first chart is Fairfield County, Connecticut. And we show it's the most populous county, 2019 population, 943,000. And you can see what's happening here. We have the break-even points are running from about 120%, clear on up to about 190%. But we look at the Yale, New Haven hospitals, and we were trying to get a feel of maybe the competition, maybe the availability of resources. We also list the number of beds that these hospitals have. You'll see that Stamford is independent. You'll see that their break-even point is high. And again, we can drill down and get some more answers on that, but also their RAND price is high. Then we jump over to New Haven County, Connecticut. Population a little bit less than Fairfield. But I have to say, you know, with Montana where I live, and I am right now with a population of 1 million, this is really an interesting comparison. So if we're in New Haven County, Connecticut, third most populous, let's take a look at the 2019 data. Now, this is interesting. We're seeing the break-even points. These are all on the same scale. So you can see that Milford, the independent, with 166 beds, the price is coming in lower than the break-even. But looking at the Yale, New Haven, look at the fifth hospital there, 1,288 beds. We can see the break even is running around 130%, but then the RAND price much higher. Again, looking at this comparison, and that gives a range to talk about what are the uses of those additional funds? What are some ideas that we can get to break even? Now, when I negotiated in Montana, my goal was I no longer wanted to pay a discount off of a charge rate. I didn't know the discount I was paying because it was private, confidential, and I didn't know the charge master rates. So I wanted to look more at a cost plus method, being an accountant, and that's why we looked at the Medicare rate as that. Finally, we get to the last county, New London County, mid-sized county. And you can see break-even points running from 108% of Medicare on up to 148, but then the comparison with the RAND prices. There's a couple of notes we put at the bottom. The hospital commercial prices do not appear to be based on the break-even. In essence, from an accountant's language, it's the price isn't based on the cost. It's not a cost plus. It's pretty inconsistent. Many of the hospitals with the highest prices and break-evens are in Fairfield County, which I'm sure doesn't surprise this group because it is closest to the New York metro area. Next slide. Okay, we looked at the Hartford system beds, same type of thing. We were trying to see what's going on with counties, what's going on with systems in different counties. The first one, it's the second most populated county, Hartford County. And you can see the two Hartford hospitals have the highest spread, largest spread between break-even and RAND. They're the two hospitals on the far left of that first graph. We go to the middle, Litchfield County, Charlotte, Hungerford, Hartford, 91 beds. We see the break-even point coming in around 120% of Medicare, but the RAND price is coming in about 160. Those two hospitals fairly close in that county in their break-even point and their RAND price. Again, you all know these hospitals better than I do, so I'm looking at it from a neutral analyst viewpoint. Finally, we look at the hospitals in Windham County, Connecticut, the least populated. And Day Kimball, I realize that you are doing some work there that has a high break-even, meaning higher costs most likely compared to the price. So we can drill down by system, we can drill down by hospital, we can drill down by county, we can kind of get a bit of flavor of what's going on. Next slide. Another thing that the hospital cost tool does is look at payer mix. So we base it on the services, the charge master, to kind of come up with what, it's not what is paid, it's the payer mix. So this gives us a little bit better look at the hospital. So the first slide will tell you what is the profit loss that this hospital is receiving. This is Johnson Memorial Hospital. What is the specific loss or profit that it's receiving from these payers? And we have Medicaid, Medicare, Medicare Advantage, if you had CHIP or other programs, and then commercial. Now, when you look at this, you say, oh my gosh, they're losing 48% on Medicaid. And you have to compare that to the payer mix. The pie chart in the middle shows you the breakdown of the payer mix. It's helpful in that you can see that how much is charity care, which is really 1%. You can see how much are the different items here. And you see that Medicaid actually is 19% of the patient of the business of this hospital. We then multiply that 19% times the 48% to come up with what is the relative impact of that. So the relative impact is a loss of 9% to the overall picture. And the same with commercial. You'll see that the 44% loss, when we're looking at the relevancy of that payer mix, comes down to 18%. And this is an important thing to look at because you need to look at the total impact. And you'll see that in this particular hospital, their break even was 131%. And the RAND commercial price is 213%. So you see that commercial high. So this is another thing that the tool does, that you can kind of get a grasp on the payer mix in comparing hospitals and counties, et cetera. Next slide. We borrowed this from the RAND Corporation, as we work a lot with them on this data, and they have been working with our data also. And we found this interesting. They found no correlation nationally between a hospital's public insurance reliance and its private insurance prices. And if that cost shifting argument was true, that you pay so little on Medicaid, we're losing 48%, so we have to charge commercial high, you would expect a positive correlation between these two variables. Additionally, the National Bureau of Economic Research found that when hospitals received an unexpected 10% increase in Medicare payment, they didn't reduce the private prices. What they tended to do was spend the money, and you didn't see that cost shift go the other way. Instead, they added new technology, increased staffing, increased payroll by 1/3, or increased acquisitions too. And so this is kind of an interesting graph to look at. Colorado found this too. We've worked a lot with them with our hospital cost tool. Colorado found the same thing when they gave some bumps in Medicaid, when they made some changes. They didn't see a corresponding relationship with commercial prices. Next slide. So some key takeaways and cost considerations that we'd like to offer is, compared to hospitals in the surrounding states, Connecticut hospitals have a relatively high median of break-even point. Maybe why is that? The RAND 3.0 price, the median, it was 208% of Medicare. Connecticut's median commercial break-even was 131% of the Medicare rates. So if you have a high break even, we can dig in, you can dig in to look, is it high losses from government programs? But then again, let's balance that. Let's look at the relative impact of that. Is it high costs? Is it efficiency? What about the other income? We know we had high other income in the COVID year. What about, let's look at that 11-year trend. Let's see what's going on with that hospital. Next slide. So thank you. NASHB's health system cost resources we list here. They're on our site. Coming up soon, hopefully early April, is the hospital cost searchable database, which we will launch, that anybody can use this very easy dashboard to come up with these same graphs and charts and analysis. And we will also have a full data set of the 10 years of data that's downloadable in Excel format, that you can do your own research. And I thank you for this opportunity.
Yes, thank you so much, Marilyn, for coming and presenting the tool. We thought it was important to share with this group, as it's something that's become more and more useful for states. And glad you're still here, because I'm sure we're going to have some questions at looking back at some of the slides. So I see at least 3 hands so far. So I'm going to go in the order that I saw them, which is Ellen, then Alan, and then Kirk. So Ellen first. Go ahead.
Thank you. Actually, I wish I could go last, but anyway, I appreciate, because I was getting very excited in my chair. When you call it losses, I understand to Medicaid and Medicare that is the way accountants talk, but that it does not necessarily mean that it is not profitable to hospitals, and it doesn't speak to whether they are, their efficiency, let's say that. So I appreciate that a great deal, and also pointing out in the literature that when Medicare raises prices or Medicare does, and also Medicaid, they spend the money. The commercial rates do not come down. Let me get this, because I have an expert here. I'm going to ask you a question. It's my understanding that in the cost reports that CMS gets, administration is not pulled out separately. The administration is apportioned to the different, other areas. And so we can't see, you know, how many vice presidents do they have and how much are they paying them? We can't look at that level of administration. It's a different level of administration than, for instance, the MLR for insurers. They can't go over 15% or 20%. There's nothing like that to compare apples to apples with hospitals, right? Is that right?
Yeah, that's right. There's two things I would say is that the Medicare cost report starts off in the schedules with the hospital bringing in their accounting records. So it's their full accounting records. And there are some schedules in the worksheet S series that do get into staffing and to costs and home office.
What was that, S or F?
S is in Sam.
Okay.
And I'd be glad to send you some stuff if you were interested in that and some spreadsheets and how we look at that, because I am working on another project with RAND where we have dug into that. You can track in these worksheets, for instance, contract labor, you can track management and overhead, but you're absolutely right, because then the next step is to allocate all that to the cost center area. So you aren't able to get to that. We've been able to find a little bit, probably not enough to help, but I would be glad to send you a couple of copies and how we've used them with the RAND information if you're interested.
I would be very interested, because that would be interesting to look at across as consolidation happens in the market, to see what happens about administration and prices and how things change. I'm just so excited by your tool. I'm going to be.
Oh, I'm excited for you to use it. I used it on a COPA here in Montana, and you can see, because we also calculate the revenue, cost, and profit by adjusted patient discharge. And you could see those were, while it was under the COPA and under the regulation, you could see just minor. And then the minute the COPA ended, the costs went up a little bit, but there was a 30% increase in prices. And so you can see, we've also done a lot of work in another state on mergers and acquisitions and looking at the hospital before and both of them before and after. And in this particular example, we saw an increase of 30% in profit on the larger, higher cost hospital, and the lower cost one had 0%. So you could see the shifting and the moving, and you can also go back and look at the patient count. So anyway,
I would be fascinated if you could send me that. And I think when you start talking about Kurt Barwis is going to be very giddy soon, because you're talking about per patient adjusted costs. And so I will shut up and let him ask this question after Alan.
Okay, so before Alan goes, I just want to, thanks, Alan. Marilyn, just for the group's edification, a COPA is a Certificate of Public Advantage, right? That Montana was doing, which is, you may want to explain that just so the group.
Sure. Yeah, and it's hitting in several states now. A COPA is Certificate of Public Advantage, and that's when a merger is not allowed. For FTC will not allow this merger because they believe there is potential of a monopoly in that area, and there's not the need to. So every state has their own laws. Montana had a law that you could form COPA. You could merge because it was advantageous to the public, but you were regulated by the Attorney General's office and the Department of Health and Human Services in Montana. Your rates were regulated and you came under review. What happens is then when you are released from the COPA, then it's, in my words, a free-for-all. And we actually worked with FTC in 2018 to do some hindsighting, and this is when we used this tool quite a bit. I worked with the state of Montana at that time, and we were able to work with FTC to see what happens after that.
Great, thank you for.
And Vicki, one thing is I will gather this information. Is it okay if I send it to you and you can route it?
Yes, no problem. We'll put it out. Thank you for that. Okay, so Alan and then Kurt.
Yeah, maybe I should yield to Kurt because he seemed pretty. Hold on, he seemed pretty anxious to respond to what Ellen was saying. So, and she set him up. So why don't you go first, Kurt?
Go ahead, Kurt.
Right. I'm not sure what I did to seem anxious, but
Well, you had that broad smile and you just leaned forward. It just looked like,
No.
you're ready.
The problem is, when I first started as a CPA for Cooper's Live brand, I was a reimbursement specialist. So I can actually remember I'm having a little bit of PTSD from doing manual cost reports on manual calculators without a computer. So, but Marilyn, thank you very much for your presentation. One of the things that I would say and comment to you is that Connecticut is a state that allows medical foundations to employ physicians. And when you look across the state, by and large, there are significant numbers of employed physicians in the state. And for Bristol Hospital, for example, there's probably 150 total physicians and APPs in a private foundation. And as a cost reporting kind of guru and a person who believes in putting costs where they belong, we at Bristol make sure that any services that are directly provided to the hospital, so for example, coverage arrangements, call coverage, all directorships, all those things are actually put into a service level agreement. And so the costs that potentially are being shown as losses on these medical foundations by some hospitals, in our particular case, are brought over to the hospital. And they do, in fact, then get played into the cost reporting process. So when you look at the hospital, and I would suggest to you that there is a significant and, I mean, really amazing amount of variation in the way hospitals in this state record those costs. Some simply just leave the costs, the losses in the medical foundations and roll them up into their overall system, profit and loss statements. And so I think the big issue with this basis of looking at it, and I'm not saying that there isn't a value in it, is the fact that there's tremendous variation in where we bring those costs into, and if we bring those costs into hospitals. And I know for Bristol Hospital, we literally go through every detailed relationship. And the other thing I'd point out is that the medical foundations by statute in Connecticut have to be governed by the physicians that are in the foundation, right? So what happens is if you're a hospital that just says, oh, you're losing money over there, you're losing money over there, and they would argue back, well, wait a minute, I'm providing bona fide services to the hospital that you'd have to pay in a fair market value to anybody else if we weren't employed. So you should reflect those things. You really get into a problem of, that physician governance component of it if they feel like, well, the hospital is not really, reflecting on the fact that we provide or valuing those services. So that would be my first comment to you. And I being in Connecticut now for 15 years, I can tell you, and being on the finance committee of CHA, the Hospital Association, I can tell you it's tremendous variation across the board. The thing that Alan mentioned, and Ellen as well, I really do think as a state, and we are constantly in this group drilling into details and wanting more and more and more. And what I really feel that we need from a comparative basis is really an efficiency measure and a severity adjusted or case mix adjusted, outpatient and inpatient metric that helps us actually make sense of and compare like size hospitals and systems. And as someone else mentioned, on a case mix adjusted basis. I know it's not perfect, but I think it would give us the comparability pre and post. But I do see the value. I understand what you're saying about pre and post mergers. You can actually look at the cost reports and see the differences. And you are absolutely correct. I am actually refiling 17, 18, and 19 right now. So it happens all the time. You find errors and mistakes. You find applications that are wrong. My big pet peeve is what we're adjusting off on our AA8s and why we're adjusting those costs off. So I'll just stop there. And I just think it's hard to use it without understanding one of the most significant cost drivers we have, which is our physician medical foundation losses and how they play into an actual hospital and how they're allocated. So does that make sense to you?
Yeah, it sure does. And thank you for those comments. And it brings up our hospital cost tool is looking at inpatient, outpatient hospital services only. We exclude all physician costs. So if they were included, the only ones we include are the physician general public that come off of Schedule 8A. So just the general care, like the emergency room, 24/7 intensive care. So the physician costs, because they're not paid through this channel that we're taking them, we just take the Medicare payments for inpatient, outpatient. Physicians, direct patient services are paid in a whole different system. They're outside of this. But we do capture that cost, and we do calculate the break even if you had included those two. So we do have that. So that is good to look at when you're looking at all this, because we're looking at inpatient, outpatient only, the hospital. Most of the time, I don't even get to include 340B profits, 340B savings, that because they purchase those physicians, now they can pay pennies for Humira, but charge $5,000 for it. So we're not bringing in those. We're looking at just the direct patient services. So I do agree with you. The purchasing of doctors can create significant losses, but at some point it's got to be reconciled with the profits from referrals, 340B, and some other things on that. That would be one thing. And then the second thing, you said have second point. Why'd I miss it? I was too wound up on the first one.
I just want to, can we, just to clarify something. So if a hospital needs a physician to be a medical director to oversee a service area or a line, right? And they're doing that out of your medical foundation, those costs are through service level agreements are now being charged to some hospitals, but not in every case, is what I'm trying to say to you. So that's where I think the great variation is. So I'm just prefer to leave them there. So it could be a significant difference. And then the other point I was making was, I feel like as a state, because we spent a lot of time in this committee asking Teresi and dig down and drill down into all kinds of costs, simple, an adjusted cost per discharge, similar to what the CMS has published. We do not have that currently in our fiscal stability reports. There are no real efficiency measures. And that's where I think, that's partially where I think we need to go, is to have both an inpatient adjusted cost per discharge and an outpatient cost adjusted per discharge. Because, when you look at what you presented, there's obviously very significant tertiary care centers with very high costs associated with providing really complex procedures. And so it's sometimes lost in that calculus, right? And I'm sure that plays into how you negotiate your rates too.
Yeah, that's a very good point. The tool itself does split inpatient, outpatient out. Now, we're not using it in the dashboard, but the tool itself does do that. But you raise a really good point, because I've wanted to come up with an efficiency measure. So I saw where CMS did that in like 2011. They published a report of the most efficient in the not. And I wanted to know how they did that, because since then they have used a classification, and it's judged by how much you basically do you make a profit off Medicare or not? Do you not, is how they classified. So NASHB reached out to the group that did develop this in 2011 and are still working. And we wanted to know the formula and wanted to find out. And they said that they don't share it, that it's all confidential. And the reason being, they said the minute they first published that, they were just hounded by hospitals and hospital associations. And why am I not on the efficient list? And you don't understand this. And there's a lot goes into it. So they continue to do the calculation, but they keep it private. And so that's where it ended. But it was interesting.
so maybe I can help you a little bit. I sent to the OHS team some of the earlier calculations and all the references from CMS. It goes back a little bit before that. And I think, you have all the information to make the calculations. And I'm happy to somebody will send you the links to the CMS research on it. It's pretty complex, but the problem is, as you point out, that it gets back to the argument that we've all had about all-cause readmissions. So CMS uses an all-cause readmission, and yeah, sure, there's things in there that probably are appropriate readmissions, but it's more of a metric that says, well, how are you doing? What direction are you going in? And we've kind of lost that battle a long time ago. And that comes up when you start to develop these kind of formulaic efficiency measures, but you need something for directional. So you made a point about pre and post merger. If you had it pre and post and use the calculation the same way, you could really start to understand what's really happening. So
thank you.
Anyway.
Thank you very much. That'd be very helpful. And thank you for this discussion.
Yeah, so
Well,
Kurt
thank you.
has given us that information and we are trying to figure out how to come up with what Kurt has recommended. So Marilyn will be tapped again for that. Marilyn also knows, she has all the financial reports that we put out to this group. So to the extent Kurt is suggesting the inconsistencies, I think some of that may be the way we're getting the reports, but also we should talk about that, because if there's a way to make this more uniform, to have better comparison, we should do that. We should dig into that. So poor Marilyn is going to be tapped. She's
It
tapped
sounds
quite a bit.
exciting. I can hardly wait to get Kurt's information now.
We've been tapping her a lot, so we're going to keep doing that. Alan, do you want to go?
Yes, thank you. Marilyn, that was excellent. Continuing in a long string of really good presentations and relevant to the issues that we have here in Connecticut from previous, and it was very enjoyable, and thank you for doing it. A couple of questions. I'm intrigued by the variability and the differences among the hospital systems between the RAND and the break even, and some of them are pretty striking. Do you have a sense? Are you able to break down what contributed? Because you talk about outpatient, inpatient, all sorts of things that hospitals provide. What particular services or factors contributed mostly to those differences? Was it amount they got for facility fees? Was it outpatient laboratory? Do you have a sense of a breakdown of what factors contribute most to that delta?
They were all different. It depends on the hospital and depends on the system. At some points, it was high investment earnings that allowed a lower break even. There's sometimes it was just higher costs, and that's why it'll be good when the tool comes out, because you're going to be able then to look at the graphs and see the net patient revenue per adjusted discharge, the cost per adjusted discharge, and the operating profit per discharge, and the net income. Now, if the net income's higher than operating per discharge, then they had a lot of other income. So you can analyze it more. So I think this gives one picture, but to drill down into that spread, what you would need to do is first look at that graph of that. And it's good to look at the trend, because you can see, was that an unusual year? Because we'll show you the break evens for 11 years for each hospital. So you can see, is this a common thing? Was that an anomaly for that year? Then you look at the unit measures, the per discharge, and you can get a comparison, because you can benchmark that to other hospitals. You can benchmark it to national. You can benchmark it to hospitals of that bed size. And you can get a range of, this appears to be higher costs. Now, to drill down any further into what's driving those operating costs would require a deeper dive into those reports that we don't have that level of detail in the tool.
Well, I was thinking more, not the costs. I was thinking more of the revenue side, on the RAND side Are there ever,
Oh,
in other
Rand,
words, is it coming from outpatient services? Is it coming from inpatient services? Is it coming from facility fees? Is it coming
Oh.
from something like that?
you'll be able to see that in the RAND, and that's online. That is link. You can download the Excel spreadsheet for your particular area, and you can look at the hospital, and you can get a number of the claims that they reviewed for that hospital, and they tell you relative price, and they provide all that information on the RAND data set. Now they're going to provide more. They're doing RAND 4.0 that should be out in May, and we will update our numbers with that. And they're going to be including a little bit more detail to get at what you're looking at. But I don't know if you have that site, Vicki. I can get it to
Yeah,
you.
we do. We do. We can share it with people. And also just remember, Alan, the data from RAND is coming from our APCD and other places.
Vicky, what did you say? The data from RAND is what?
The data, RAND, Connecticut is in the RAND study.
Yes.
And that majority of that data from Connecticut is coming from our APCD. So we have some of that detail in the APCD that we've been sharing repeatedly. I think we need to come back to this group with a little more detail on what has come out of the APCD and newer, some of the analysis that we've shared in another setting, we should share with this group too. So we have some idea, right, of breakdowns of different kinds of services by category. ED, like the trend in ED, the trend in imaging, the trend in labs, we have that. So we can share that. And that's kind of what, RAND used, and they broke it down by particular hospital and outpatient. So that is in the RAND study, but it's also kind of based on the APCD. So I think we should bring those two together, maybe.
Right, since it's used
Maybe
as
Chris
a
will come
negotiation.
and present. Maybe Chris.
Since it could be used as a negotiating tool, it's my sense, and Kurt, you can tell me if I'm right or wrong, that hospitals don't necessarily negotiate everything as a percentage of Medicare. They might negotiate outpatient services, inpatient services, service line things separately, differently. It's not necessarily one thing. Kurt, is that correct?
Yeah, it is actually much more of an overall percent increase negotiation, not specific rate. And what really messes up the cost to charge or reimbursement comparison is that sorry, my dog's going crazy over here, is really the fact that after you finish the negotiation, you go and you spread those costs to charges to get the reimbursement rate. And there's not always a rhyme or reason of how you spread those increases across the entire set of charges. Your charge master may have, has thousands of different places to charge it. So, to your point, you're absolutely right. It's more of a negotiation of what's the overall increase. And then what really kind of messes up the whole accounting system is how you have to spread it. And it happens so quickly that, you try to pick, different ones and say, I'm going to put it here, I'm going to put it here. So hopefully that helps explain. Does that make sense, Marilyn? I mean, that's been my experience. And that's why hospital accounting is totally messed up. The relationship between cost and charge is a mess.
Okay, second question, if you don't mind, is did you see it, Marilyn? Did you notice a correlation between system size and cost reduction? Because that's actually one of the rationales for consolidation, because you can get an economy of scale. No, you did not.
Yeah, the hospital cost. So with consolidation, did I see hospital cost reduction?
Yes.
Now, I did not dig in deep in Connecticut, but in other states, no, I have not seen that correlation at all. The other thing that I do off to the side is analyze the audited financial statements of a system. And that you can't break out by hospital, it's the full system. And I have not seen, when mergers, I have not seen cost reductions. I haven't seen it. But again, my scope is with two other states I've worked on. I have not dug in enough too, but we can sure look at that.
Coming soon,
Because just seeing that,
you know, Marilyn, coming soon.
And really, Vicky's doing that. I think Vicky's team, I think
So-
you've got some on that, don't you?
Yeah, we're trying to do that. Yes, we're trying to do that, and but will be tapping you a little bit.
Okay.
yeah, and Vicky, just seeing that for the first time and going by pretty fast, it's hard to get a real sense of what it is. But my initial sense was that it looked like the large systems did have lower costs than the smaller ones. But on the other hand, they also in some cases tended to have higher RAND number percentage.
Yeah, I
And
think,
so-
Alan, just
and
to
so
be
they-
clear, I think you're confusing cost with the Medicare break-even point, which.
Yeah, right.
Yeah.
Oh, okay.
So the chart shows, Marilyn could correct me if I'm wrong, the differential between the break-even point as a percentage of Medicare and the actual prices. That's what the chart shows. So it's not
Right, isn't
fair
that, but
that's cost, right?
isn't that cost really? Medicare break even is a reflection of cost?
No, the break even is what commercial would have to pay to cover their own patient costs, to cover any shortfall on public programs, to cover all disallowed Medicare costs, that we're going to cover everything. And then also take in any other income, other expense. So it's more a price comparison. If you were to pay the hospital as a multiple of Medicare, you would pay that and it would cover their expenses, that multiple of Medicare, a commercial payer. And so it's more a price comparison, and that spread, what I used it for was negotiating. But thanks to my new friend here, Kurt, I might be using it to look at efficiency too. So it's really not cost, but I understand what you're saying, because when revenue covers expenses and it equals expenses, then you kind of go, well, that's your costs. But it's better to think of it as the price variance.
Okay, thank you.
All set, Alan? Okay, I'm gonna move on to Jill and then Pat.
Thanks, Vicki. And hi, Marilyn. We were once on a panel in DC in 2018 when I was hobbling around with a broken ankle, recovering from a broken ankle. So hello.
I recognized you immediately. Yes.
At that time, I was talking not about outrageous hospital prices. I was talking about outrageous pharma prices, but it's all kind of the same area. Vicki, I'm just wondering, how do we take this information and merge it in with the cost growth benchmark information? I mean, it feels like they're related in some way. I mean, this information I think is helping. Cost growth benchmark is looking at growth of, increases, but this is looking at prices that are probably too high to begin with, but I don't know in your brain if you've thought about how these things all relate or not. Just curious.
I have. I think the tool is more discreetly around negotiations between providers and payers, and also useful for us to measure impacts to the market. That, at a larger degree, get to spending growth potentially, but I don't think we've made, we haven't taken it yet to the next step to see what to do with it. And part of it is I want to air it out with this group. I want to air it out with people. I want people to have their questions answered. I want people to be able to go through the tool themselves to feel comfortable with it, including our hospital, the hospitals who are on here. I know Kurt's on, to feel like the tool, accurately reflects their experience. I mean, part of that is we have to have, I feel like it's a credible tool. I feel pretty strongly it's credible, but I do think we need everybody to be on the same page about the credibility of it. And to undertake some additional analyses that, based on the questions like Kurt has asked and others have asked, to feel like we can account for the differentials. Are we doing apples to apples between hospitals now that we know that maybe physician groups are being accounted for differently from hospital to hospital? I would want to know that, because I do not want to suggest it applies in a certain way to a certain hospital if it doesn't. So I think we need to plow into it more before I would directly connect it. But maybe that's too long an answer, but But I do think it's a valuable tool, and I do want to use it for what Maryland has been doing in other states, is comparing market issues as the state has advanced in market concentration. So that's one area where I would use it. But other question? Want to make another? Do you have another question, Jill, or do you want to? No? You're done already? Okay. All right, I'm going to let Pat go then. Go ahead, Pat.
Okay, well, thank you for that, because part of it is we've gotten some really good data in different segments of over the course of the last year of the cabinet. And part of it is, I hope we take out time to map out how we're using it and what are the questions we want answered, and using a variety of tools. So I appreciate what you said, Vicki, and it would be nice to see kind of I'd say a decision tree and map, but rather analysis to get to answer what questions. That would be, I think, really helpful. What are the burning questions strategically? How are we going to use the data? I think that would be helpful for all of us. Mine is kind of a micro question, which is, am I correct that the APCD still doesn't have ERISA data, correct?
It does not have self-funded ERISA data.
Okay, which is a huge chunk of the covered lives in Connecticut. So my only question is, do you think that affects the RAND number significantly, or this is a good proxy for the RAND number without that chunk of ERISA data?
I'm going to say I think it pretty closely approximates. I'm not, there are group plans in there. There are small group plans. There's the state employee plan. The likelihood that the self-funded plans are paying significantly more per unit service, I think would be surprising given the way the negotiations go. But I could be wrong. Marilyn, do you have a?
Oh, I was going to say, now the RAND study is open to any ERISA plan, any public and any self-funded plans, and the plan itself decides whether or not to participate. So I don't know if the Connecticut RAND number has ERISA plans in it, and RAND keeps that information confidential as far as what employers have submitted information.
Yeah, and I mean, for the benchmark, just to be clear to this group, for the benchmark data collection, we have all the data. We have self-funded, aggregate, and fully insured, and state employee, Medicaid, Medicare.
Hey.
So we're getting everything. Corrections, veterans, all those expenditures are coming to us. So at least we have them at that level. We don't have them at a claim level because we would run into a challenge.
Wonderful, though. You're far ahead of other states. That'd be wonderful to have.
Okay. So I see, let's see, Ellen has another question. Anybody else? Go ahead, Ellen.
Well, this was to you, Vicki. Actually, I liked Pat's question. I mean, we get a lot of data and it comes from different places, and you hear about apples and oranges, and when you try to make heads or tails of it. So I think looking at the data we have and mapping it to the questions is a really important public exercise to have. I know that didn't happen when the cost cap was developed, and I've been an outspoken critic of some of that and how it looks at various things. And I think a public conversation that's bigger than just the cost cap, that also includes things like, I would love to know more about hospital administration. How are they spending their money when they merge, or when they get more, their prices go up, those kinds of things. So I think the questions are really important. We did do an exercise like that around how to use the data and questions, but it was quite a while ago, and we have a lot more information. And maybe we should bring Marilyn back when we have these questions. She can say that'd be nice, but you can't have that, or this is possible.
I'm happy to go through questions. I think on the cost benchmark, we're happy to answer questions about how the data gets used in that process. I do think there's a lot of data in here that needs to be reconciled. This started because we had the financial data in our office, and we wanted to use the financial data, right, to to better understand how that impacts pricing, how that impacts services, which is why we reached out as soon as, sitting on the NASP cost group as I do, we were given a preview of this tool. And as soon as we saw the preview, we decided we would use it in Connecticut to better understand our hospital systems. Then the next step is how does that inform other policy decisions or the benchmark, et cetera. We haven't gotten there, but I do agree that we need to reconcile that stuff and bring these data together in a way that makes sense. How do you translate A to B, B to C, C to D? So I don't disagree.
I get to Pat's point, the questions should drive how we look at the data, and that should be a public process.
And that's.
Yeah,
if I could just follow up. Go ahead, Pat.
If I could just follow up, because I think there's micro and macro questions, and I'm thinking about what are the big strategic questions that a variety of sources of data that we as a state around health policy need to think about, and how do we use this data to kind of help us have good background and some really concrete kind of analysis to help us answer the question, which are bigger, might be big policy questions.
Yeah, I think a lot of these questions go to the market and go to, where is the market going in Connecticut, which ties into the governor's proposal around the study to see where the market goes. So I think you can be assured that we will be using that when that process has to be a stakeholder process. So that will be coming back here to start. And I anticipate what Maryland has done to be a significant part of how we embark on that study. That's just one example. CON is another. I can think of 3 or 4 right now off the top of my head where it becomes relevant. So that's a situation where I think we have to come back and have a discussion about the questions, right? I don't know that we're going to catalog all these questions in a half hour, but I think it's fair for people to pose them, right? We could try to bring them together. We can have a meeting to just discuss that if we want, and how we move forward on that. Jill, do you have another question? I see your hand.
Yeah, it was just more of a comment. One of those slides when you were looking at Windham County and the difference between Windham Hospital and Bacchus Hospital, at Universal Healthcare Foundation, we've definitely been involved in looking at the service cuts that are going on all over the state of, labor and delivery at 3 different hospitals as an example. And so the whole level, as we're talking about questions and data, where does need come in? Because when you're looking at pricing and profits in some cases, and a big source of information that's relevant to that is what's your service mix? What kind of services are you offering? Which ones are super profitable? Which ones aren't so super profitable? And when you see a situation where one hospital, Bacchus Hospital, I really don't know why, but they've just always had very high rates. I don't know where it came from, or they have high profits, at least. They've always had them. And now you see they've got labor and delivery, and Windham, which always has struggled financially, doesn't. So, how do we make sure that we're layering need into this whole discussion? Because it's not only about money. It's about making sure that the needs are being met, and that a hospital's financial incentives, when they don't match up with community needs, is actually one of the fundamental issues that we're really dealing with.
So, and I think that should be part of our discussions on that study and laying the groundwork for that study and working together on that. That should be part of that. I cannot obviously in this forum talk about any specific transactions that are in our office right now, but we'll say, because we're in a regulatory process, but we'll say that is that's one of the reasons we asked for the funding to do this broader plan for the future for the state, is to base it on what we think the needs of the future of the state are. What should the plan for the state be? Where should the state be going directionally with its resources based on current inventory, based on where providers are, based on the services we actually need, the demography of the state, the languages, all the kinds of things that have to go into a true health systems plan, which frankly, we haven't been able to do one since 2012. So we are behind. We need, and it can't just be for today, by the way, it has to be for directionally, where's the future going to be? And then we can look at where should transactions be coming in or not, as the case may be, to align with that plan for the future. And all these things are part of that. Where's the need? What does the current market look like? What is the price? What are the prices going on in the market? What are the costs? All of that is pieced together there. So that could be the framework to feed these questions into. I'm just throwing that out there as a discussion, but that is a potential here. So there's a lot of work to be done on that, and frankly, a short period of time. So this group is going to have to play a big role, I think, with respect to that, that plan. So get your questions ready, because there's a lot of work that's going to have to go into that. And the voices around this table are pretty representative in a way that I think can contribute pretty heavily to that discussion. And not saying this is the only table, but this is a table that can definitely contribute to that discussion.
That's great. Thank you.
You're welcome. Any other questions for Marilyn? I knew this would trigger a lot of conversation. I think that's a good thing. And, you know, I know we'll be going back to Marilyn. We've been back and forth a few times with some further analyses based on the financials we have. If there's something we're missing between our financial status report and other financials that we get that people think is a gap in the analysis, they should tell us so we can kind of get that analysis done and work with Marilyn and help Marilyn work on this issue with Kurt, you know, on the efficiency measure. You know, we have been talking about an efficiency measure, and I think we have to figure out how to do that. But we wanted to at least get this out to people to understand it's out there. It's public. It's going to be on the website, as Marilyn said, be updated more thoroughly. People can have dashboards, everything else. And then we'll be updated with the newest RAND information coming in May, right? So actually, Marilyn, so when, maybe you can like sort of discreetly say what is out when on the NASHP site so people know. And I'll
Certainly
share everything you send.
We're hoping for the launch of the site on early April, and it will include the ability to do a lot of comparisons by bed size, by system, by independent. You can compare state, you can compare to national, and you can compare the per adjusted discharge numbers I explained. You can look at them for 10 years. You can look at one that I like is the cost to charge ratio. We briefly touched on that. That's hospital costs divided by charges. And we typically show that, and we see that for most hospitals that is decreasing. But then the question is that decreasing because costs came down or charges went up? So we have another graph that shows total charges and total costs. And what you typically see is the costs stay fairly here, but you'll see the charges go up. And typically insurance company negotiations are discount off charges. So that's something important to look at. We'll also show you by system the profits made in different states, although that doesn't really impact you guys that much. You can look by state. You can see what's happening. You can compare yourself. You can compare individual hospitals on all those different metrics. Then there are, and we only picked, I think, 50 of the metrics, and the tool actually produces close to 200. So we're going to be working on version 2. And version 2 will include some more of these metrics and will be updated with 2020 Medicare cost reports. And we're looking for that to roll out next fall. But hopefully in April, you'll be able to get a snapshot of that. We will be, and we'll be looking for feedback on it.
Okay, that's great. And as I think I've heard from Maureen, who's not on here today from NASHP, that some hospitals have actually reached out to NASHP, I think, about the tool themselves. So not to like get you in a pinch in terms of getting about 25 people running to you at once, but if any hospital in Connecticut wanted to talk to you about the tool, I think that NASHP is open to that, or has been open to that in other states. So this
Yes,
is actually our
yes,
first.
we are. because that helps us revise it too. We worked a lot in one particular state with a large health system and with some independent hospitals and gave them the whole tool that was not password protected and asked them to look at the formulas, tell us, what can we improve, what's not. And that helped us refine it quite a bit.
That's great. So Kurt looks like, do you have your hand up again, Kurt? I just want to make sure I'm getting new hands.
I
versus-
did. I just,
Okay, go ahead.
I've been, just one comment, Marilyn, that, in processing it, that the chart where you show what you would need in terms of a percentage of Medicare and then what the actual reimbursement looks like. Maybe it would be helpful on that chart to put the hospital's, percentage of government pay, and that might help reduce some of the confusion, because people naturally look at it and say, oh my God, their costs look like they're 200% or 300% of Medicare, when in fact, that's not what you're demonstrating on that chart. You're saying, how much does the hospital need to break even on the commercials to make up for their costs and the percentage. And you showed earlier charts where you showed how a hospital could be adversely impacted by the fact that, like, we have almost a 70% government pay at Bristol. So yeah, of course, it looks like we have to make up all this ground. So if you just simply had on that chart, what is the percentage of government pay, it might help people understand why that would be greater than 100% of Medicare. You follow what I'm saying?
Yeah. So what you're saying is, on the break even, to be able to let the user see that to break even, they're covering this amount of loss from government payers.
Right. Exactly. Just a suggestion. And I definitely want to get the full download of my hospital. So thank you. If you're willing to share. Thanks.
Certainly.
Thanks.
Great. Anyone else have any questions? No? Okay, well, Marilyn, thank you so much for coming and demonstrating the tool. I'm sure you may get follow-ups independently from people on the call, which is fine. And whatever you send me, obviously we will share it out with the full cabinet. So everybody gets the same information. And with that, we might be able to end 19 minutes early. So I can't imagine anyone's going to complain about that. So unless there's any other question out there, I will ask for a motion to adjourn the meeting.
So moved.
Thank you, Pat. Is there a second, please?
Second.
Thank you, Kurt. And with that, we'll adjourn, and we will be back together next month. I'm sorry, I don't have the date handy, but second Tuesday of the month, same bat time, same bat channel. We'll see everybody. And everybody have a good month. Take care all.
Thank you. Great presentation. Great meeting.